A 41-year-old with a 3-day history of shaking chills, high fever, headache, abdominal pain, and generalized weakness came to hospital. Notice the pattern here. This is systemic illness, not just gastroenteritis. Interestingly, mild diarrhea had started 2 days earlier, but was actually improving when the fever began. This sequence is important. In typhoid, diarrhea comes first but isn't the dominant feature. In his history, he recalls eating various local foods, particularly from street vendors, a classic exposure for typhoid in endemic areas. On physical examination, the patient appears ill. His abdomen is diffusely tender, and critically, his liver and spleen are enlarged, hepatosplenomegaly. There's no jaundice. Some patients develop rose spots, a characteristic pink macular rash spreading from trunk to extremities, though not mentioned in this case. What investigations should we order? Blood culture and stool culture are essential, but we must also consider the differential diagnosis in a febrile patient from an endemic area, viral serology for dengue, and peripheral blood smear for malaria parasites. Fever in the tropics requires broad thinking. The patient was admitted and started on empirical antibiotics. Blood culture yielded Salmonella typhi, confirming enteric fever. After 10 days of ciprofloxacin treatment, he recovered completely. Now let's understand how Salmonella typhi causes this systemic disease. Entry occurs through the oral route via contaminated food or water. The bacteria must first survive the gastric acidity. Only organisms in sufficient numbers or in buffered food make it through. Once in the small intestine, Salmonella attaches specifically to M cells in the jejunum. Remember M cells? They're specialized antigen sampling cells we saw with EPEC. S. typhi invades by endocytosis and enters the submucosa. Rather than causing local inflammation immediately, the bacteria are phagocytosed by macrophages. But here's the trick. S. typhi survives and multiplies inside these macrophages. Most bacteria are killed by macrophages, but S. typhi has adapted to live within them. The infected macrophages carry bacteria to mesenteric lymph nodes, where it multiplies. From there, bacteria spread through blood and lymphatics throughout the body, which explains the systemic symptoms. S. typhi then invades organs of the reticuloendothelial system, liver, spleen, and bone marrow. This explains the hepatosplenomegaly we saw in our patient. It also colonizes the bile duct, Peyer's patches, kidneys, gallbladder, and skin. Here's the critical final step. Bacteria multiply in the gallbladder and bile ducts, then re-enter the intestine from the bile duct in massive numbers during the 2nd to 3rd week of illness. This triggers a strong inflammatory response in Peyer's patches, leading to ulceration. This is when intestinal complications like perforation can occur. This explains the clinical timeline. Systemic symptoms dominate early, while intestinal complications develop later. Timing is everything in diagnosing enteric fever. Let's understand when and what to collect. First, a critical rule. Collect specimens before antimicrobials are started. Once antibiotics begin, isolation rates plummet. The specimens we collect are blood, stool, and urine, but timing determines success. In the first week of illness, blood culture has the maximum chance of isolation, up to 90% positive. This is because bacteremia is at its peak. Our patient's blood culture was positive, confirming he was in the bacteremic phase. In the 2nd week, the chance of isolation from blood decreases with time as the immune response kicks in and bacteria localize to tissues. By the 3rd week, bacteria can be isolated from urine, as they're excreted through the kidneys. Here's an important point. S. typhi can be isolated from stool throughout the entire course of illness, from the 1st week onward. However, stool culture is less sensitive than blood culture in the 1st week. What if you suspect typhoid but cultures are negative, perhaps because the patient already took some antibiotics? Bone marrow culture is ideal. It has the highest yield, even in partially treated cases. Bone marrow culture can remain positive even when blood cultures are negative. Finally, for detecting the carrier state, people who harbor S. typhi in their gallbladder months after recovery, we use serological detection of Vi antigen, the capsular polysaccharide. Let's discuss the actual laboratory techniques for isolating Salmonella typhi. For blood and urine, we use blood agar and McConkey agar, standard bacterial culture media. For stool, we need selective media, because stool contains millions of normal flora bacteria. We use DCA, deoxycholate citrate agar, and XLD, xylose-lysine deoxycholate agar. These media suppress normal flora, while allowing Salmonella to grow. An important characteristic, Salmonella is motile. This helps in identification. Once colonies grow, We identify them by colony characteristics and biochemical tests. The confirmatory test is slide agglutination, using specific antisera against Salmonella antigens. We must also perform antibiotic susceptibility testing, because multi-drug-resistant typhoid is increasingly common. Additionally, we can detect specific Salmonella antibodies in the patient's serum, using the Weidel test, immunochromatographic tests, or ELISA. However, culture remains the gold standard. For treatment of enteric fever, the primary antibiotics are ciprofloxacin and ceftriaxone. However, fluoroquinolone resistance is increasing globally, so ceftriaxone is often preferred, especially in South Asia. Treatment typically lasts 10 to 14 days, as we saw in our case patient. For prevention, we use both general and specific measures. General measures include improved sanitation and food hygiene. The classic teaching is to boil it, cook it, peel it, or forget it when traveling to endemic areas. For specific prevention, we have vaccines. There are two types. The parenteral vaccine contains VI capsular polysaccharide antigen. It's given as an injection and is suitable for individuals 2 years of age or older. It provides protection for about 3 years. The oral live attenuated vaccine is given as capsules and is suitable for individuals 6 years of age or older. It requires multiple doses and provides protection for about 5 years. Neither vaccine is 100% protective, so food and water precautions remain essential even for vaccinated individuals. Vaccines are recommended for travelers to endemic areas and high-risk populations, like food handlers. Now let's shift to a different clinical presentation caused by non-typhoidal Salmonella. 6 members from a single family presented over 2 days with low-grade fever, abdominal cramps, vomiting, and diarrhea. Notice the difference already. This is classic gastroenteritis, not systemic illness. All 6 had eaten together at a birthday dinner in a private home. They all ate chicken and stuffing approximately 24 hours before symptom onset. This is a classic foodborne outbreak. The short incubation period, about 24 hours, and the food source chicken, immediately suggest non-typhoidal Salmonella, most commonly S. enteritidis or S. typhimurium. This demonstrates a key epidemiological principle. When multiple people who shared a meal develop similar symptoms within a short time frame, think common source outbreak. The pathogenesis diagram shows how non-typhoidal Salmonella causes gastroenteritis, and it's fundamentally different from S. typhi. After ingestion of contaminated food, commonly poultry, eggs, or dairy, bacteria that survive gastric acid reach the small intestine. Unlike S. typhi, these Salmonella strains remain localized to the intestinal mucosa. They invade intestinal epithelial cells, but instead of disseminating systemically, they trigger an intense local inflammatory response. The invasion stimulates release of pro-inflammatory cytokines, inducing acute inflammation in the intestinal wall. This inflammatory reaction causes the diarrhea and may lead to ulceration and destruction of the mucosa. The key difference: S. typhi causes systemic disease with bacteremia, while non-typhoidal Salmonella causes localized gastroenteritis. Let's detail the pathogenic steps for non-typhoidal Salmonella gastroenteritis. First, pathogenic Salmonella in contaminated food must survive passage through the gastric acid barrier. High inoculum doses or consumption with buffered foods like dairy help survival. Once in the intestine, they invade the intestinal mucosa directly. This invasion of epithelial cells is detected by the immune system. The invasion stimulates release of pro-inflammatory cytokines like IL-8, which recruit neutrophils and other inflammatory cells to the site. This induces an inflammatory reaction in the intestinal wall, the hallmark of inflammatory diarrhea. You'll see white blood cells in the stool under microscopy. The inflammation causes diarrhea through multiple mechanisms: increased secretion, decreased absorption, and increased motility. In severe cases, it may lead to ulceration and destruction of the mucosa, resulting in bloody diarrhea. Clinically, patients develop acute diarrhea, often watery but may become bloody, along with abdominal cramps, nausea, vomiting, and fever. The illness is usually self-limited, lasting 4 to 7 days in healthy individuals. Antibiotics are generally not recommended for uncomplicated gastroenteritis, as they may prolong the carrier state. To summarize, remember: same genus, completely different diseases. S. typhi equals systemic typhoid fever. Non-typhoidal Salmonella equals food poisoning gastroenteritis. Understanding these distinctions helps with proper diagnosis, appropriate investigations, and correct management decisions. Think systemically for typhoid, locally for gastroenteritis.